And I'm going to be talking today about some of the natural language processing algorithms and systems that we've developed and implemented here for the COVID shared resource. So I've been working at VINCI for about 5 years under the director, Dr. Scott Duvall, and with Dr. Olga Patterson, who's the applied NLP lead, developing natural language processing systems to extract clinically relevant information from the VA's EHR. As I go through these slides, there's going to be a lot of different topics that we cover here, and so feel free to ask any questions in the chat. I'll try to be aware of that, or in the Q&A section as well. I believe Rob's going to be also monitoring that when needed, but I'll try to be aware. So feel free to chime in if I've skimmed over anything, and yeah, let me know. And so as an outline, I'm going to start with this shared resource and give you a little bit of background there. And then we'll talk about natural language processing, what it is and how it's used in medicine for both clinical and operational uses. And then from there, we'll get into a little more detail and start talking about the NLP systems that have been deployed and implemented here at the VA and for this shared resource. So the shared resource is a resource that's been developed by VINCI under the direction of the Office of Research and Development. There are a lot of people that have been involved here. I'm certainly not the main player here or person that's been creating the shared resource, so this one won't be going into all of the details of the resource. There are other Cyberseminars that will go into a bit more detail there, but there's a lot of collaborators in research and both in the operational space that have helped put this together. It's been created to ensure that as a research community, we can have a good starting point for research, but also that this data can be available as early as possible. This resource includes patients from the VA who are either confirmed as having COVID or have been tested for COVID. So again, one of the goals here is to make sure that this data is available as quickly and consistently as possible. As I go throughout these slides in this presentation, I'm going to be describing different phenotypes that exist within the VA EHR and how they're expressed in the data. In the context of electronic health records, and here for this presentation, you can think of a phenotype, or rather a computable phenotype, as any clinical condition or characteristic that can be queried from the EHR in a manner that then allows researchers to define populations and cohorts or ask the questions that they're most interested in using these queries. So a phenotype defined in this way can be anything ranging from stage of cancer, drug side effects, the medication that they might take, smoking status, infections. It's pretty broad to just say anything that you'll be identifying here in the EHR. And so this shared resource, and when we develop these phenotypes, it's done in an iterative manner and hopefully in a transparent manner. There's a wiki that I think might have been linked there. If not, the wiki describes all of these phenotypes and the definitions and how they've been created. Again, I can't state enough that collaboration is key here. We aren't creating at VINCI all of these phenotypes. They've come from existing resources or from researchers who have used the shared resource and maybe provide input or have created their own, and collaboration is key here. And anybody who's interested or wants to improve the shared resources is encouraged to. They can contact VINCI at vinci@va.gov, I'll put it at the bottom, or provide any feedback on some of these resources that we've already created here. Let's see, next slide here. So the conditions, or rather the shared resource is structured in a way where all of these conditions and phenotypes are broadly related to an index date. The complete index date can be found in the wiki again, but you can think of it primarily as the date that's most relevant for COVID-related research here. It's the date of their negative test or their positive test, or rather their most recent negative test if they never tested positive for COVID. And so when we're looking at all of these phenotypes and these conditions, we're looking at them in the context of this index date, when it was relevant to them. And so if we break it down a little further, there's the phenotypes that occurred before the index date, these what we're going to call pre-index observations, and those might include existing medications or comorbidities or relevant medical history that a patient might have. Let's see, we break it down here. And those phenotypes that occur after an index date are referred to as the post-index observations here. And these are the ones that are going to be primarily related to a patient's COVID treatment or their outcomes after being diagnosed with COVID. So these are phenotypes that aren't just specific to COVID, but they occurred for these patients after that index date. And then researchers can work with that data as they want from there. We break it down even further in the shared resource. So there's the pre-indexed observations that might exist up to 2 years before this index date, those that might be a little bit more relevant 30 days before the index date, and then we have a 7-day window and a 60-day window. So there, in the shared resource, you'll see a lot of phenotypes that will be 2 years, 30-day, 7-day, or 60-day, and they'll have timestamps as well for researchers to use, or for you to use to however you think it's most relevant there. So again, there are a lot of people involved here at VINCI and a lot of operational partners. This is just a small list of those people that have been helping here. And there are a lot of different phenotypes and conditions that are in the shared resource as well. So there's a wiki page if you want to browse all of the conditions that exist there. In the wiki, you'll find resources on how to use the data or best practices with some queries or code in there as well. And then also VINCI provides customer support. So you can contact VINCI at va.gov and get some help there, or provide feedback again if you have feedback for the shared resource on how it can be improved. On the wiki as well, you'll find some cohort statistics for some of these phenotypes, but also just broadly about the shared resource, some high-level statistics that you might or might not find helpful. They're there for you to look at. And again, as a reminder, it's important to remember what the purpose of the shared resource is. These phenotypes that are created to give researchers a head start. They're not necessarily meant to finish their research. They've been validated iteratively. Again, there's feedback from the community. But the hope here is that with these phenotypes, researchers don't have to start from the beginning and come up with all the definitions here. They can have the resources that have been provided in our community and lean on the work that's already been done. Again, we constantly go through iterations to validate these phenotypes, but a specific definition that we use here might not answer every research question for your project or for your question. And so it's always important that when you're using these resources, you provide or do your own internal QA to understand how these variables are expressed and how it might affect your research. And again, if there's anything that might be valuable or important that you identify for other researchers, we're very open to feedback, and we want to make sure that we can improve as well here. But going on, we're going to get into some of these phenotypes that have been derived through natural language processing. So in this slide, you'll see some of the phenotypes that currently exist in the shared resource and those that have been derived using NLP. Before we get into too much detail with them, it's really important to remember that the NLP isn't a one-size-fits-all solution. There's not an NLP system that you just apply to the notes or to use to extract data. Language is infinite in many ways. It's incredibly complex. And medical concepts that will exist in natural language can vary with every bit of linguistic complexity that natural language that you use daily has. And so this complexity can exist at a term level, with one term being defined one way in a clinical setting that might not make sense outside of a clinical setting. So the complexity can exist at a syntactic level or at a sentence level, or even at a paragraph level. There's a lot of complexity depending on how you define these concepts. In a clinical setting, the section of a document that you're in might change the actual interpretation of a term. And so while a term might be defined one way, in one clinical subdomain, it might be have a different definition in a different subdomain. And so it's all of these different aspects of language have to be accounted for when you're developing NLP systems and looking at a concept of interest here. The variety might also exist at a document level or even at an entire admission period level, where certain concepts are relevant for one instance and maybe not relevant for another one. And it's important to remember that NLP and how we've implemented it here doesn't exist in a vacuum. It can be used to augment or to supplement or to create data elements that aren't either completely or consistently captured in the EHR, and we'll go into some of those here. But as with all the phenotypes that I have described here, these NLP phenotypes and systems that we've developed have been derived iteratively. They get tweaked and they get updated, and they can certainly be improved. They've been validated as well, but welcome feedback here. And they come from different sources and different starting points. So we're going to dig into that a little bit. In the early stages of the pandemic, one of the first things we did is try to identify any NLP systems that we already had that might be useful for researchers. So vital signs was a good example of that. This is a system that we developed in 2015, working with Makoto Jones, and a few others here, and it was related to sepsis. And for this project, what we were trying to do was extract the vital signs that you can find in text, so that we can supplement the existing vital signs data that exists. Some of you might have worked with vital signs in a structured manner. There are variables that exist there, but not with the breadth or the complexity that you can find in the notes. So here's a few examples that'll show you the complexity of language and how these systems work and how vital signs can be expressed. So this first example, let's see. I want to see if this pointer's working. Well, might not be, but top left, you can see that first box. It's pretty clear. Temperature, 98.1, pulse, 64, respiration, 20. This might be an easier clinical concept for us to extract if it was always expressed that way. But if we move down to these next boxes, you can see that all of those values are there. They're all present for this patient, but they're in completely different contexts. So this next one, vitals expressed as T, RR, pulse, and BP. It's structured in a similar way to that first one, but the term complexity changes here, and you have to account for that when working with natural language in the EHR. But then you get patterns like this next one on the right, vitals, and it's just a string of numbers. In these cases, the data is still there, and it's important that we extract it. And so the NLP systems that are developed have to be able to capture this complexity, and it's done iteratively with annotation, with people annotating it, and with clinical input to make sure that it's actually relevant or meets these clinical concepts and definitions that we're working with. So you can see that as it goes down, the complexity or the way that these concepts are expressed can be all over the place. And so when we're developing NLP systems, it's important that we try to capture everything that's possible. But also, it depends on the research question that you're interested in here. Because for some people, it might just be, or did a certain vital sign ever pass a certain threshold? But others, when they're studying sepsis, in this example, they needed to know how the vital signs changed over time, and they needed to get all of these instances extracted with more sensitivity, or rather to get all of it there. So the first system that was implemented here was vital signs. It was validated again using contemporary data to make sure that it still worked the way that we intended, because it's important to remember as well that over time, the way these things are expressed changed. And so a system that was developed maybe a few years ago to extract vital signs won't perform exactly the same as a current system in the time of COVID, especially with COVID being in mind. Any of these phenotypes that were developed for past pneumonia cohorts or similar projects here would need to be looked at again because the data changes a lot. But this is an example of pretty concrete concepts that are extracted by NLP. NLP doesn't just, or you don't have to just extract values that are explicit like this. Another system that's been developed is the reason for stay. And this system leans on existing NLP systems as well. There's a system called CTAKES, which identifies a number of symptoms and conditions that might be found in notes, and identifies whether it was affirmed or negated, if there's any uncertainty, or if it was perhaps a historical mention. This specific system was used to extract these concepts from the EDIS, the emergency discharge log, which will contain little snippets of text to provide a brief summary of the patient. And so for this system, the symptoms were extracted as well as the conditions here. Another NLP system that has been under development here is the COVID-19 screening, or these templates that have been approached. This is a specific document that we identified as occurring frequently, and it started occurring more and more, and it was really well structured. It included things like this example here: the resident does not have new or worsening cough, and in this visual you can see that a cough is extracted, shortness of breath is identified, sore throat. And so this system was developed using Python. On the right here we have MedSpacey, which is an open source NLP system that's under development here with VINCI and some other VA collaborators, if anybody wants to look in more detail at some of the underlying code or technology that's used here. But this document occurred so frequently, there was an opportunity that was realized, and that was that rather than developing a system to identify cough or developing a system to identify patients that had diarrhea or certain symptoms, you could actually parse this entire structured document out and structure the answers to each of these questions. So for this system, the COVID screening asks some very specific questions, and then there's some answers at the end, and we're able to automate the process or structure it so that that information can then be queried, and you can identify the patients that answered all of these COVID-19 screenings one way or another, depending on what you were looking for there. It's important to know or to understand when NLP should be used. So when we looked at vitals, again, vital signs exist as a structured data, but not as frequently as some might need. Another example of that here is supplemental oxygen or a high flow nasal cannula. This is an upset plot. And so what we're looking at is, we knew that high flow, or this was a specific question that was asked from researchers within the community. We had a variable called oxygenation any, which was, was there supplemental oxygen given to a patient? There's some CPT codes and there's some ICD codes there. Specifically with high flow nasal cannula, there's some orderable items. There's a number of sources all over the place that you might be able to find this information in. But what we had identified was that where it exists most regularly or most often is in the notes. And so in this upset plot, you can see on the left-hand side is the total number of patients. This was a sample of 10,000 patients, 10,000 random patients that were hospitalized. So on the left histogram there, you can see the total number of patients that were identified by each of these different methods. So that one was the structured orderable item. Another one was the vitals table, the high O2. That was if there was supplemental oxygen in the vitals table. A high flow other, those last two are NLP variables or things that were extracted from text. And you can see that when NLP identified a patient on high-flow nasal cannula, it was also identified by some of these other structured data, or rather when these other structured phenotypes, or rather, what am I trying to say? These structured variables here, when they identified high-flow nasal cannula, NLP identified them almost every single time, whereas the inverse is not true. When we noted that the patient was described as being or using supplemental oxygen with natural language processing, they might have been missing that data with their CPT codes or in some of those other structured data elements. And so for this one, we realized that NLP was needed to completely extract or identify all patients with supplemental oxygen. This one's not released yet. Hopefully it will be soon, but the idea here is that we wanted to identify everybody with the NLP system, regardless of these other structured data types. Whereas a different phenotype here is mechanical ventilation. This one was one of the first ones that was requested for, I think, more obvious reasons here in COVID. And so some of the existing phenotypes that were used included ICD-10 and CPT codes. And so if we start on the left here, that's how everything began, or that's how this phenotype began, rather. It did a pretty good job using just the ICD-10 codes and CPT codes of identifying patients who did require mechanical ventilation. But it was unclear if it captured all patients. And so the team that was working on this in the shared resource, they also included intubation codes, which did identify more patients. But one thing that was a real concern at the time was if there was a delay in when the data actually arrived in CDW. And so they started incorporating more data like the local drugs, intubation, or drugs that would be given to a patient who was intubated. And then from here, after we started validating some charts, we had a pretty good idea of when patients started being mechanically ventilated. But what wasn't clear using this structured data was when they stopped being mechanically ventilated. And that was especially relevant at the time because we weren't sure to what extent we would need to identify the total number of patients who were currently on a ventilator, and if that was something that we needed to account for with this data. And so we started looking at the notes, TIU, this natural language processing tier 1, to see if we can identify any indication of extubations and start trying to find the stop date for patients that were mechanically ventilated. And when we did this, we started identifying patients that didn't show up at all with the ICD and CPT codes. But what we also identified was that within these periods of a patient being intubated, there were multiple intubations, and these things were only expressed in the text. And so for this phenotype, you might not necessarily need natural language processing to just identify if a patient was ever mechanically ventilated. It performed quite well and had a reasonable sensitivity. But when we started including the NLP here and extracting these intubations and extubations, the sensitivity improved, and we were able to start creating a more complex phenotype here to better understand patients that were reintubated or that might be in a worse off state here. And so I'm going to go into a little more detail here with this system. It uses the structured data that I described below. So this mechanical ventilation phenotype. It uses medication data, intubation procedure codes, discharge dates, and death dates. These are all things to try to build that window of when a patient might have started and when the patient might have stopped. And then in the unstructured clinical notes, we use natural language processing to identify intubation dates, the status, whether they were described as currently being on, their prone status. Frequently when patients are intubated, they're described as being in a prone position, or rather they're treated in a prone position to hopefully improve outcomes. But then also the NLP system, this specific one was used to identify extubation dates. Let's see. So these structured events, again, this flowchart here kind of roughly describes the entire system that was used to describe the mechanical ventilation phenotype that's in the shared resource. It includes structured events that we described there. It includes these rule-based NLP events, which are the intubations, the extubations, whether the patient's on a ventilator currently or off a ventilator. And the NLP events work by first identifying some anchor terms. So those are things like extubated, extubation, or intubation, which would be reintubation here, or describing the patient as being on a ventilator. These are, 6 examples here. The variety of just individual terms that exist, there's hundreds of terms that could describe an extubation or an intubation or ventilation here. And those term sets were developed iteratively with clinical input, and then again validated on patients' charts to make sure that when these terms exist, they actually describe a patient being extubated for mechanical ventilation, and that there's no other possible definitions that could have been found here. So these are the anchor terms, and the way the system works is it then identified modifier terms, so something like yesterday or today. Oh, that rolled over. The patient currently is on, or instances of negation. And so when you put these anchor terms and modifier terms all together, you can start building patterns. And with these patterns, you can find cases like the patient fails to extubate or remains ventilated. All of these things are used to describe the status of the patient at any given time. All right. Oh, I didn't see the Q&A. Rob, were there any, I guess, lingering questions to pause real quick? I wasn't looking at Q&A. I was looking at the chat there.
There are a few questions. One person asked early on if you have phenotypes for chronic conditions. I'm not sure if you addressed that in the meantime. And then somebody else asked about stats. Can they be a CSV file? Anything else I think we can save to the end of the webinar?
Yeah. So yes, chronic conditions, comorbidities, pre-existing conditions, those do exist. And again, the wiki page there will describe all of the different phenotypes that have been implemented in the shared resource. And as far as the CSV, I think they're represented in a few ways. The wiki page, I'm trying to think. There's if the question was about something that can be imported and maybe used for their own dashboards or processes, I'm not positive. There are dashboards that use the data there and that are provided by CSphere, but I'm not sure if that answers the specific question here. But we can get into that if we want later. Okay. So continuing on here, we had our anchor terms here. And again, at this point, what this NLP system is trying to do is identify extubations and intubations so that we can build this or better understand this window or time frame that a patient might have been mechanically ventilated. So we're trying to identify starts and stops that are related to mechanical ventilation. So in this first example, failed to extubate, that failed term is negating extubation, but it's not negating whether the patient was actually mechanically ventilated or not. It just means they're still ventilated in this instance. So those top two instances can be interpreted the same way, failed to extubate or remains ventilated. And these are some examples of how the language that natural language processing works with changes for every concept, and you can't just apply an algorithm that extracts things and states whether they're relevant to your research or questions or not. They change and evolve with each of these concepts that we're working with. So with these NLP patterns, we then create these time-stamped events that occur. So these 1, 2, 3, 4, 5 examples on the left in a database might look like this table on the right. So there's a start date, there's a stop date. This extubation might have just been excluded, that top one, because it's not precise enough. But using these time-stamped instances and dates, we can then start building a better picture to understand specific patients. So here's an example patient timeline. This patient arrived at the hospital and was admitted on day 1. They were placed in a prone position on day 2 and given supplemental oxygen. They were intubated and ventilated on day 4 and successfully extubated on day 7, but their condition worsened, and on day 10 they might have been reintubated, and then on day 12 they were successfully extubated again and discharged on day 15. So that might be a really rapid progression for somebody who gets reintubated twice. This is just an example patient here. But you can see that on each of these days there was a distinct start and stop time. And so for this mechanical phenotype, we can start taking those time-stamped extracted events and create this next step in our logic, which is, well, I'm pointing to sequence logic there, but what I wanted to point to here was the ventilation events. So with the structured events that we talked about, the medications and the NLP extracted intubations and extubations, we get a table that is currently released called the Supplemental Ventilator Events Table. In this context, events just means an event that was related to ventilation, not ventilator events. Unfortunately, that's, I think, an overloaded term there, and probably should have chosen a different term because ventilator event in a clinical setting implies something different. But for this use case, these are time-stamped start and stop instances related to mechanical ventilation using the structured data and the NLP extracted data here. So this is what an event table might look like for this specific patient. We can see that on the 4th, there was an induction medication. So what triggered this patient's mechanical ventilation period was not NLP. It was the fact that they were given a medication specific to being induced. And then there was another, on the next day, NLP did identify an intubation, but because of this induction medication occurring first, that's the start date for this patient. So you can see all of these events that occurred. A patient that is mechanically ventilated might have 60 or 100 different events that are extracted either through the structured data or through NLP here. And so this next part is the sequence logic that we described. We wanted to break that down into a more usable bit of information for the shared resource. So again, if your research question needs this kind of granularity, the supplemental ventilator events table is released in roughly this format, giving you every single instance that happened related to this patient's mechanical ventilation. But for the shared resource, we wanted to roll that up further, and we implement the sequence logic, which then takes all of these events and tries to find distinct windows of intubation. So for this one, you have this first start date on the 4th, and then the first stop date on the 7th. Every start instance or on instance after that first one is ignored because the first one already occurred, and the patient will be described as on a ventilator until there's some kind of stop event that occurs. And so for this patient, the patient was extubated. And then that same logic occurs if there's stop events after a stop event. There won't be a new sequence triggered, because frequently what will happen is the example that you see here, the patient was extubated yesterday, or the patient was intubated on the 4th to the 8th, and it doesn't really trigger a completely new intubation period. But here the patient was re-intubated on the 10th, and then extubated again. And so for our sequence logic, we roll this table up, the ventilator events table here, into supplemental ventilator sequences table here. And this table is a distinct row per ventilator period. So a patient might have multiple instances where they were ventilated, and it would be expressed in this example as 2 rows, a patient that started on the 4th, ended on the 7th, started again on the 10th, ended on the 12th, with some details about why the logic flagged the patient as such. But again, if the need is there, all of the events that were used in this logic are also available. So if there's certain validation or questions about specific patients, about whether they were actually ventilated, every single medication, CPT code, ICD code, or the snippet of text that was extracted can be viewed. It's completely transparent there, and you can see why that decision was made, not just some date specifying that a decision was made. But going even further, so we have these sequences, we have these periods of time, but if we start looking at more patients, we see things like this. This is something that we started seeing after initially releasing the phenotype. We saw that when it stated that patients were ventilated, it was correct. It was assessed for sensitivity and specificity. But we started seeing patients like this where they were given propofol. There was some NLP that was identified a stop date, and so they were ventilated, but for just one day, or maybe even all in the same day. And that didn't really fit what we thought we would be seeing when we're working with COVID patients. And so through this iterative process, we started chart reviewing these patients, and what we identified was that patients who were intubated for procedures will appear very similarly to patients that are intubated for respiratory distress. And depending on the research question that you might have, that's a really important distinction. If you're limiting to patients that are in the ICU who are COVID positive and maybe took remdesivir or something like that, it might not be, these patients might not show up, but the shared resources for all of the patients that have been tested. And so we needed to find a way of distinguishing whether it was an intubation for emergent reasons or an intubation for procedural reasons. And so the last bit of this mechanical ventilation phenotype that we implement is this procedure classification. So taking these sequences, there's then a machine learning classifier that's applied to these sequences with the whole context of a patient's admission. And so this classifier looks at the total time that a patient was intubated, whether there was a procedure on a specific day, on the day that they were ventilated, a procedure that might be not emergent. It can't use any of these single features to make the decision, because there might be a patient who's getting a procedure or intubated for a procedure, but then they go on to become in a worse state, and then their ventilation would be emergent at that point. And so there's a lot of information that or features about this patient's profile that need to be included in this procedure classifier. And then there's a flag that's implemented in this supplemental ventilator events table to indicate whether this classifier labeled the patient as being, or rather labeled the ventilation period as being emergent or elective and procedural. To see what that looks like at a patient level, though, we processed, I think, so this analysis was done back in September, but we processed an entire year's worth of data. And what you see in this histogram is the top row are those ventilation periods that were flagged as elective. And what we found was that it looks like what we might expect for elective intubations here. Each of these dips are weekends. And when we get even deeper down into the data, you'll see dips on holidays. And so the peaks here are weekdays. And most importantly, what we see is right here about mid-March, that's when elective procedures were stopped as the pandemic picked up. And these are just start periods, not total patients on a ventilator, so don't take too much from this histogram other than when these patients were started. And what you can see is that these elective procedures almost completely stopped, and that's when we started seeing emergent procedures, this bottom row, pick up. And then sometime in May and June, elective procedures picked back up, and these emergent procedures kind of stayed the same. And when we're looking at them now, the emergent procedures are going down. People are getting intubated less frequently for COVID as, the practices change, and so they won't be intubated as much. But what we saw was that there was a need to identify patients or intubation periods here as either elective or emergent, and that was expressed with what we would expect in a clinical setting. But again, we didn't just look at this histogram and call it good. We do validate every component of the system, and so at the time, the rule-based NLP system was validated for whether it could actually identify intubations and extubations. If we just take a patient having any ventilator event and describe that as ever never. You can get accuracy in PPV here. Sensitivity performed well, but I put an asterisk there because we were looking at emergent intubations, and so it's a little unclear if we were picking up all of the procedural intubations here because those look quite different, but we were picking up all of the emergent procedures here. And then the classifier, its ability to determine whether yes or no this was elective or emergent was assessed separately as well. So each different component of the system was assessed at different times, and then all together to give us sensitivity and specificity for these patients. All right, let me pause real quick. Are there any other questions there that I might have missed? Prioritized.
Sure, there are a number of questions, Patrick, but
great.
You don't want to wait till the end to address
I can wait. Yeah, no, that's fine. I wasn't sure if there were anything that I was leaving out before I continued.
It's your choice.
Okay, so let's continue then. I'll get them all later. And so when we take all of these phenotypes together, those that are extracted by NLP, those that exist in the shared resource, we can start building these patient profiles that are a lot more detailed. So what we're looking at here is, this is a histogram, and these are all of the different events that might be extracted, either existing already. So we have OMOP procedures, we have the index date. So index date for this patient, you can see happened at the same time. So they were tested, and at that same time, there were some OMOP procedure codes. They were admitted to the ICU right away, and then the vital system started picking up pulse oximetry values for this patient. And so if we go through and walk through in a little more detail here, we have an example patient here. They were admitted to the ICU on the same day as their admission date, and then they were discharged sometime later, roughly middle, late of October. And so if we look at just the ventilation data that was extracted by NLP, we can see that they were started on a ventilator almost immediately from when they were admitted. We have these start dates. Let's see if I can actually get that squiggly annotation working. Maybe not. All right, well, start dates, you can see that's in the blue there. That's a mechanical ventilation start date, the one that's highlighted. And then you can see that they stopped the ventilator, that kind of teal greenish column on the right. There were a number of instances picked up there saying that the patient was extubated. And then there's not much else there. And so we can start adding more detail to build this patient profile. So here, if we look at the supplemental oxygen, you can see that this patient, after they were extubated, now there's a lot more instances here. On the 30th-ish, you can see those stop events. There were only a couple descriptions of the patient being extubated. And what you're looking at here now is the patient was on supplemental oxygen, and it was described a lot. And so the patient might have been, these instances that are extracted might have been from a nursing note or some kind of monitoring of the patient. But you can see that after that mechanical ventilation period, there's a number of instances with supplemental oxygen. But altogether, there's just a lot going on. And NLP helps to supplement what we have, or what we had with the existing OMOP procedures, or rather the existing phenotypes. I used OMOP procedure codes for this visualization. It's not all OMOP in the shared resource, but you can see some of the phenotypes that might be structured here and how they exist in a patient's timeline with some of the NLP extracted instances there. This patient had symptoms that were extracted from the EDIS log. They had procedures that were noted in their structured data, but they also had that mechanical ventilation and supplemental data and vitals information extracted that helped build this whole profile. So if you look at other patients, you can see that the data shows up where we would expect. For a high flow nasal cannula on this one, it showed up a day before they were intubated, and then there's no more mention of high flow nasal cannula until there was an extubation, and again, it showed up for that patient. This is at a really detailed patient level, but obviously, or it's to give you an idea of how this data might look for individual patients, but bringing it all together, you can set your questions however you want, and do something like track ventilator use within the VA and just define any patient using these windows. So what this one is, or what this histogram shows you, is ventilators in use, and flagged by that mechanical ventilation phenotype as an emergent ventilation. So this was done in August, and you can see that first wave of the pandemic, far more ventilators that were in use. That second wave, there were a lot more patients that were getting COVID. There were a lot more people that were getting COVID, rather, but the ventilation didn't go as up to the same degree. And then again, in this third October wave, when this was queried, that data wasn't quite up to date, but it was a similar process there. So I'm going to stop there for now. Again, there are other HSR&D cyberseminars, including introductions to NLP, so a lot more detailed information about NLP. I didn't really go into how-tos of NLP here. I described how some of the NLP systems are implemented in the shared resource. There's more detailed introductions to the shared resource. There's the wiki, which will provide the actual definitions that are used for all of the phenotypes that are in the shared resource. And then again, there's the help desk at vinci@va.gov that will answer any questions you might have, or definitely take feedback if you notice anything that can be improved with this, either the NLP data or the shared resource here. So I'll stop there then and open it up to questions and see if I missed anything there. Thanks, everybody.
Great, thank you, Patrick. We have a few questions queued up. And anybody, if you have questions at this time, please submit them to the Q&A section over on the right-hand side of the slides, and I'll read them to Patrick. But first up, this person asks, if we are interested in performing NLP on VA data, are there models/tutorials to follow based on prior efforts?
So, yeah, I would start with the Cyberseminar. Here again, there's a couple of introductions to NLP at the VA, but a lot of the work that's done will get or has been published, and there's open source tools that are used. We use, again, MedSpacey was the Python environment or framework that we use. We also use a Java framework called Leo, which was developed by VINCI here at the VA. And there's a lot of resources that you can find either at VINCI that go into detail about NLP or through HSR&D, and then just the listserv or out in the community, or again, vinci@va.gov if you have specific questions. But there's a lot of work out there, yeah, to hopefully give you a start.
Thanks. Many of these phenotypes are of great interest outside the COVID cohort. Are there plans to make some set of these part of the operational research data, like ventilation time, part of the OMOP, et cetera?
Yeah, so the phenotypes that can be derived with structured data, again, are in the wiki page, and those can be used by anybody for their questions or the research questions that are outside of the COVID cohort. There's certainly a hope or plan that we can, for some of these NLP systems, it requires a lot of heavy processing weekly in order to get this data for the COVID cohort. So I'm not going to say that we're not going to implement some of these in the future, but it's hard to say what will be implemented going forward. They'll have to be prioritized, but the code can be released for specific research questions, or again, the really high priority ones, like you mentioned, that might become an operational need going forward, and that will be implemented. But to give you just a little example here, this COVID, or rather the mechanical ventilation system, or rather all of these, they have to process at this point about 4 million documents every week in order to keep the data up to date. And so if this was something that was potentially released, that would have to be dealt with there. But there are examples of us doing this. There's the ejection fraction phenotype that was used or developed previously, and that one is now run, I can't remember how frequently, I think maybe weekly, but that's a table that's just available for all patients at the VA. And so I don't have specific answers on these phenotypes being implemented operationally, but it's possible, and it's been done with other past projects here. And I would imagine that some of these, that will be the case going forward.
Thank you. Could you please provide some examples of products or practice implications implications informed by findings from these NLP analyses?
Let's see. So the wiki pages have some summary statistics that are available there. I don't know. I was going to try to read that question there. I might have missed that. There aren't, I don't think, any publications yet about some of them out here. There are these presentations now. And then I think whatever you might be looking for would be on the wiki. The HSR&D website does have different publications that have been done using the shared resource. But I don't know if that's exactly what the question was looking for there. Sorry.
And we can move on and they can clarify. A person is asking for you to kindly share the wiki link. I'm not sure if that's possible. I tried to look through the slides and I didn't find one to put in the chat.
I didn't do it as a slide, but yeah, I think I can do that in the chat here. Let me just open that up. Yeah, I'll look at that, or try to give you that here in just a second.
Okay.
Okay.
Yeah, meanwhile, another person asks, are the codes for the phenotypes available to all researchers?
The NLP, the code related to the NLP algorithms haven't all been released yet. Again, they're being iteratively developed. The output is available for the COVID cohorts. The hope is to release them open source when they get to that point. But again, there's some post-processing that occurs, and they've been developed continually. But that is the plan. Okay. I can't paste in the, oh, maybe I can paste this in the chat. All attendees. Okay, can you see the link to that wiki now? I put it in the chat rather than the Q&A.
Oh, right. Yeah. I can't see it because you sent it to all attendees, but somebody will let us know. Another person asks, Patrick, how can we request access to VA data for NLP research?
All of those questions can be answered at the VINCI homepage. They describe the process, the regulatory process there, and I'll post that now in the chat as well. You have to have an IRB approved study, and then from there, there's a DART request form to ask for different levels of access. And so to develop natural language processing systems, you would have to be able to see at a SSN level, or to see the patient's notes and actual text data. And so I just I believe this is access through the intranet, but I just pasted the VINCI Central website as well.
Great, and they can also email vinci@va.gov, correct?
Yeah.
Okay. Next up, what's the current or trending sentiment on the VINCI team's effort size? Meaning, do you anticipate increases in size of the VINCI team, or do you think it'll be static for the rest of this year?
Oh, we're hiring. I mean, as far as VINCI effort specific to COVID, I wouldn't be able to answer that. I mean, we're continually working. It takes up the bulk of my time. There are other projects within VINCI that happen as well, or within all of the different folks here. But VINCI is hiring. It's growing. I'd say effort is just more, and there's more demand. If that answered that.
Great. Give me a moment while I try to parse through some of these questions that I may have asked previously.
Okay.
This person's asking how to get to the wiki, and you can email vinci@va.gov. Has natural language processes been used to identify veterans facing homelessness, food insecurity, or other social problems or phenotypes?
Yeah, absolutely. There's a few papers. They used UEMA, the same frameworks and tools that we did to identify patients that might be facing homelessness. There's a current project that's already going on, I know, with one of the MedSpacey developers, Alec Chapman, to work on homelessness here. Social determinants of health and other things that might be less concrete in the EHR are certainly sought after using natural language processing. So personally myself, I'm not working on any projects at the moment related to food insecurity, but if they are described in the notes by their physicians and documented, NLP can hypothetically be used to extract that. And I say hypothetically just because some of these concepts might be a little more ambiguous or harder to extract there, but NLP can only be as good as clinical documentation. And so if it's documented and there's interest, it can be extracted to some degree. And whether that's really specific or really sensitive might depend on the approach and the concept that you're looking for, but it has been used, and it certainly can be used for other questions that you might be interested in that aren't published out there yet.
Okay, we have a couple left. What classification method is used to evaluate results from unstructured data?
Yeah, it depends on the question. So I'm going to go back to my slide, I think, where I described the mechanical ventilation. Some researchers might just want to know ever, never, was the patient ever mechanically ventilated? And so for that, we used sensitivity and specificity and we looked at patients' whole charts and reviewed their charts to see if they were mechanically ventilated. But there's also precision for some of these NLP systems, which would identify if the concept is ever noted or extracted by the NLP system, how frequently is it correct? And then there's recall that's used to see the system's ability to identify the concepts when they exist, but sensitivity might be used at a patient level. And so those are the types of, those metrics change depending on the research question that you're looking for, because for some concepts, we don't need to or want to extract every single mention of some phenotype in the notes. So for example, another project that we had worked on was metastatic prostate cancer. That was something where when a patient has metastatic prostate cancer, they'll have it going forward. And we don't need to identify every single time that a clinician mentioned that they have metastatic prostate cancer. We just need to know that when we identify a patient as having it, that we have to be correct. So we really cared about precision for that one, but we still tested on sensitivity at a patient level as well. So it changes. All of them, I guess, is the answer there. All of the metrics.
Thank you. Do you or VINCI have involved using NLP for veteran suicide prevention / prediction? Where would be good resources to look?
Yeah. We've used natural language processing to identify different aspects related to suicide. I haven't personally done any prediction. There's risks associated with patients who may commit suicide, but I think it's important to specify that I'm just one researcher that uses natural language processing within VINCI. VINCI, our applied NLP group has there's a few more of us that use natural language processing, but NLP is not just done by our group here with the shared resource or within VINCI. There's a lot of NLP researchers out there that use VA data and work with these concepts. So I know that that's something that's actively being studied. And so I can't answer exactly who is working on it right now, but I know there are people working towards it, both with and without NLP. And again, we do in some respect, both here in VINCI, but there's a lot of researchers that use NLP and access the notes through VINCI, but aren't necessarily part of VINCI, if that answers that one.
Well, thank you, Patrick. That's about all the time that we have left, and I think we got through most of the questions. If we didn't get through to your question, please send whatever you have to vinci@va.gov. Patrick, if you have closing comments, now would be the time.
No, that is it. Thank you, everybody, for listening. And again, feel free to ask questions and let me know, and check out those resources. Thanks for attending.